Hello everybody. Today we'll be talking about PCOS. In this lecture, we'll talk about polycystic ovarian syndrome. Welcome to Medimantra. So, when we are knowing PCOS or learning about it, first we need to know the physiology behind how menstruation really occurs and what the hormonal levels are changed, how it is changed. So, if you consider a cycle, I'm repeating it once more. Earlier, also, I have told if you consider a 28 days cycle for a female, consider that at 14th day there is ovulation. So the second half of the cycle is always constant. Remember, the secretory phase of the female is always constant. Secretory phase is constant. It is the proliferative phase which is changing. It is the proliferative phase which is changing. So if the cycle length is 40 days, suppose if it is 40 days, then your ovulation occurs 40 minus 14 at 26th day. So the proliferative phase cycle, the day keeps on changing, but the secretory phase is always of 14 days. So you can estimate by the cycle length of the cycle what will be the day at which ovulation occurs. So the basic defect in PCOS is there is LH persistent rise. There is persistent rise in LH rather than an LH surge. So what actually happens in a normal female is that in the initial part of the cycle, FSH rises. When FSH is rising, then it produces the follicles. The follicles are recruited in the ovary and the follicles keep growing. When the follicles are growing, they secrete estradiol. Estradiol is secreted. This estradiol keeps on rising until a level when the estradiol reaches a peak and remains at peak for the next 48 hours. So, estradiol remaining at peak for the next 48 hours is a trigger for LH, is a trigger for luteinizing hormone to be secreted by the anterior pituitary. So, luteinizing hormone starts increasing. Now this increase in luteinizing hormone is called the LH surge. Surge means where at the level where the LH keeps increasing. It increases for the next 24 hours and then remains at peak for the next 12 hours. Remaining at peak for the next 12 hours is a trigger for ovulation to occur. It is a trigger for ovulation to occur. So basically from the LH surge, from the time from which LH has started increasing, 36 hours is required for ovulation. It is very important because in IVF cycles, we generally give injection HCG, human chorionic gonadotrophin injections are given because it has similar action to luteinizing hormone. Luteinizing hormone is very costly in the market. So synthetic HCG is injected and after injecting HCG, we wait for 36 hours and then we can go for ovum pickup because after 36 hours ovulation starts. Now what actually happens in PCOS? In PCOS patients, initially the FSH rises and FSH will raise the estradiol also in the body. But what happens is that estradiol remaining at peak generally increases the LH. But here what happens, once the LH has risen, this LH is persistently high. It will never grow and it will never fall down. That is, there is no LH surge and LH peak. It will be persistently high. So the LH is always persistently high. So the basic defect is increase in LH which is persistently high. Now coming to the ovaries, ovaries have two compartments within them. One is the granulosa cell compartment, the other is theca cell compartment. So granulosa cells are being stimulated by FSH hormone, follicle stimulating hormone, and granulosa cells are the follicles and they secrete estradiol. Whereas theca cell compartment is stimulated by luteinizing hormone from the anterior pituitary and they secrete androgen. So they secrete androgen. And androgen again get converted to estrone E1 by peripheral aromatization. Peripheral aromatization. Very important. By aromatization of androgen, E1 is produced, that is estrone, whereas E2 is produced by granulosa cell compartment under the effect of FSH. Now in PCOS, what actually is happening? The LH is persistently high. So LH is always high. When LH is persistently high, the theca cells will produce more and more of androgen. Now this androgen is dominantly in the form of DHEA, that is dehydroepiandrosterone is the predominant form of androgen. This dehydroepiandrosterone or androstenedione gets converted to testosterone and later dihydrotestosterone by 5-alpha reductase. So basically in PCOS, what all problems have happened? Number one, there is persistent increase in luteinizing hormone. Because of persistent increase in luteinizing hormone, the theca cells have produced more and more of androgen. So male-like characters are increasing, and because androgen is produced, more and more of E1 is also produced. Estrone is produced besides E2, because E2 is also persistently high and as there is no ovulation. And since LH level is never rising and falling, this rising and falling LH is responsible for ovulation. But since LH is always at the peak and it is persistently high, so there is no ovulation. So ovulation does not take place, the follicles do not rupture. If there is no ovulation, there is no production of progesterone. So progesterone hormone is not there in the body. And if there is no progesterone, then progesterone will not rise and progesterone will not fall. Fall of progesterone and estrogen is associated with menses. So patient will not have proper menses. So proper menses won't occur because progesterone is not present. So progesterone ka fall is also required for proper menses to occur. So these are the consequences of PCOS. So basically, if I have to make a flowchart of what is the pathophysiology of PCOS, I will tell PCOS is basically PCOS or PCOD is polycystic ovarian syndrome, which is also called Steen-Leventhal syndrome. Steen-Leventhal syndrome. Steen-Leventhal syndrome it is called because it was first discovered by two scientists. One was Steen and the other one was Leventhal. So basically in this thing, the main defect is increase in androgens, and increase in androgens is because of persistently high LH. Now this increase in androgen will lead to hirsutism and acne. Hirsutism and acne will be produced. Hirsutism is when hair growth is high. So basically it is the terminal hair growth in the body, not the villous hair but terminal hair. And acne is produced by the sebum production. Increased sebum production is there because of androgen. Apart from that, there will be peripheral aromatization. So E1 will be produced besides E2. E2 is also produced more in the ovaries. So E1 and E2 are high. And the third thing which androgens will do is it will hamper the lipid profile of the patient. It will hamper the lipid profile. So patients will have their cholesterol, HDL level will high. So triglyceride level will high. Your HDL level will decrease. Good cholesterol is HDL, which will decrease, and there will be increase in LDL, low density lipoprotein. Very low density lipoprotein VLDL will increase. So because of that, patient's lipid profile will be bad, and in future these patients will have chances of heart disease. Heart attack will rise. So heart disease, all the atherosclerosis and all chances will rise because of deranged lipid profile. Now this estrogen, when estrogen is high, what effect will it have? Number one, it will decrease the FSH level. So follicle stimulating hormone by negative feedback will decrease. At the same time, estrogen remaining persistently high will always increase the LH level more. So by this will be a vicious cycle. Once the LH level was already high, Then the estrogen level was also high because there was anovulation, and because of that LH level again got higher. So basically the LH FSH ratio, the LH to FSH ratio will be more than 3:1. This is diagnostic of PCOS. So if the LH level is more than FSH by 3:1, then it is diagnostic of PCOS. Apart from that, estrogen high can lead to endometrial hyperplasia also. Endometrial hyperplasia, because endometrium of the uterus is dependent upon estrogen for its hyperplasia. So endometrial hyperplasia will occur, and then this can be predisposing for endometrial carcinoma in future. Endometrial carcinoma. Now LH FSH being very high, there will be persistently high LH, so there will be no LH surge. No LH surge. अगर LH surge नहीं हो रहा है, then there will be no ovulation, and if there is no ovulation, there will be no corpus luteum formation. No corpus luteum formation. And if there is no corpus luteum formation, then the decrease in progesterone will occur. Decrease in progesterone will lead to then your oligomenorrhea and amenorrhea. Oligomenorrhea and amenorrhea, secondary amenorrhea can occur because of this. Patient will not have any bleeding. At the same time, if there is no ovulation, then egg won't be released and patient will complain of infertility. So infertility can be one of the important cause is PCOS. So these all things keep on occurring, and it is a vicious triad. If you go to look at the hormonal levels of the patient at this level, then always remember FSH is the highest. Always there is FSH rise in such patients. There is no surge, peak and fall of FSH. At the same time, LH will also be very much persistently raised. So overall, LH is the hormone which will be highest raised, followed by FSH, followed by your estradiol level, and then your progesterone will always be at the bottom. Progesterone level will be lowest. So basically question will come, which hormone will be the least and the highest. So LH will be at the highest and progesterone hormone will be at the lowest. Now what are the features? Knowing this, knowing the pathophysiology, now what patients will complain of? Patients can have 2 or 3 types of feature. One is the hyperandrogenism. Number 1 is hyperandrogenism. Because the androgen levels are high, so hyperandrogenism can occur. Because of hyperandrogenism, patient can have acne, patient can have hirsutism, and then patient can have changes in voice. But changes in voice is not much seen. It is the acne and hirsutism which are seen much. The second feature which patients come is with irregularity of menstrual cycle. Irregular menstrual cycle. Irregular menstrual cycle can be in the form of oligomenorrhea or amenorrhea. How do you diagnose oligomenorrhea? Oligomenorrhea, for oligomenorrhea to occur, menses should be, one cycle should be more than 45 days. If one cycle length is more than 45 days, you tell it to be oliguria, or the second definition can be less than 8 cycles in 1 year. In 1 year, if you have less than 8 cycles in a year, then you tell patient is having oligomenorrhea, means menses are less. Apart from that, the third feature which patients will not have complaint, but they will have deranged lipid profile. Deranged lipid profile. Deranged lipid profile is because of persistently increased androgen. It is not because of estrogen or decrease in progesterone, it is the androgen. The fourth thing which will be found is insulin resistance. Very important, insulin resistance. Now what do you mean by insulin resistance? When patients have increase in glucose tolerance test, if you do an oral glucose challenge test or glucose tolerance test, then patient will have sugars in the impaired glucose tolerance level, or they will have frank diabetes level, frank diabetes mellitus. Why this is occurring? This is because if there is obesity along with this, then the peripheral fat and all things which are being produced, they are resistant to insulin. So basically it is a part of the metabolic syndrome. It is a part of the metabolic syndrome which is occurring. Now, what do you mean by metabolic syndrome? This is also a question which comes in your NEET PG. Metabolic syndrome is also called the X syndrome. It is also called the X syndrome. So, metabolic X syndrome, X metabolic syndrome is a consequence of number one is abdominal obesity. Number one is abdominal obesity. Nowadays, metabolic syndrome is increasing very much because people are having sedentary lifestyle. So, abdominal obesity कैसे पता चलता है? Waist circumference more than 88 centimeters or 35 inches in females or 90 centimeters or 38 inches in males. Okay, is an example of abdominal obesity. So remember the female one, because in PCOS the female one will be important. Abdominal waist circumference more than 88 centimeters or 35 inches in female is abdominal obesity. Number two, second criteria is triglyceride levels. Triglyceride level more than 150 milligrams per deciliter. At the same time, the good cholesterol will also decrease. So HDL cholesterol less than 50 milligrams per deciliter. These are the two from lipid profile, these two criteria. The fourth criteria which is seen is blood pressure. So blood pressure more than equal 130 by 85 is another feature of your metabolic X syndrome. And the fifth feature which is found is fasting blood sugar if between 110 to 126. So 110 to 126 milligram per deciliter, or and 2 hours postprandial between 140 to 199 milligrams per deciliter. So these are in the impaired glucose tolerance level. They are not frank diabetes. Frank diabetes will be fasting more than 126 and postprandial 200 and above. So if 3 out of 5, any 3 out of 5 criteria are present, you tell the patient is having metabolic syndrome. So let us revise once again: abdominal obesity, triglyceride, high density lipoprotein less, blood pressure and fasting blood sugar. So any of this is present. So metabolic syndrome is associated with insulin resistance and is found in PCOS patients. Now we have studied about the pathophysiologies. Now what are the clinical features which we need to know? So in clinical features, remember there is a Rotterdam's criteria, which is very rigorously followed in case of PCOS, Rotterdam's criteria. So what does Rotterdam's criteria say? 2 out of these 3 criteria if present, then you say diagnose the patient as PCOS. Number 1, it should be ovulatory dysfunction. Means patient should be having either secondary amenorrhea or patient can have oligomenorrhea, as I have already told. Number 2 is hyperandrogenism. It can be either clinical or it can be biochemical, means tested positive. Okay, so clinical hyperandrogenism can be in the form of acne, can be in the form of hirsutism. So these are, or in the form of maybe alopecia. So these are forms of clinical hyperandrogenism. Whereas biochemical hyperandrogenism can be in the form of, you can test for serum free testosterone level. If it is between 70 to 150 milligrams per deciliter, nanograms per deciliter, then it is suggestive of biochemical this PCOS. But remember that in normal females, the free testosterone level is generally less than 50 nanograms per deciliter, whereas in normal males it is above 200 nanograms per deciliter. But if it is between that, that is 50 to 150, then it is in the PCOS range. So more than normal female but less than a normal male. The third feature which is present in Rotterdam's criteria is ultrasound feature of PCOS, which is also called PCOM. What do you mean by PCOM? Polycystic ovarian morphology. So it is seen in ultrasound. In ultrasound, if you see the ovaries, you will find a necklace pattern of follicles arranged around the periphery, and none of the follicles are maturing, and there is no dominant follicle and there is no rupture. So a characteristic necklace pattern can be seen. So it means that presence of 12 or more cysts, if you find 12 or more cysts, follicular cysts present, and their size should be between 2 to 9 millimeter, okay, in any one of the ovaries, or the size of the volume of the ovary more than 10 ml can be criteria for PCOM. Okay, so means your ovary, the volume should be more than 10 ml, and there should be 12 or more cysts of 2 to 9 mm each, ranging from 2 to 9 mm, then you diagnose it as PCOM. So any two of the three criteria is present, then you say Rotterdam's criteria is fulfilled. But remember, at this same time, I would also like to tell you that there are 4 phenotypes of PCOS. So there are 4 phenotypes of PCOS. 4 phenotypes of PCOS, what are they? Number 1, it can be A, B, C and D. A, phenotype B, phenotype C and phenotype D. So phenotype A is the classical type of PCOS, whereby all three criteria are fulfilled. That is, it means patient will have ultrasound feature also. Ultrasound में भी PCOM दिखेगा, necklace pattern मिलेगा. Plus patient will have hyperandrogenism. Plus patient will have menstrual irregularity also. All the three features will be there. Then patient is type A PCOS. Next, coming to type B. Type B is basically adolescent PCOS. तो कम उम्र के बच्चे from menarche till 19 years of age, if they develop PCOS, generally they have type B. But adults can also have type B. More of adolescents will have. So adolescent patients do not have PCOM नहीं दिखता है, क्योंकि वो छोटे बच्चे होते हैं, उनके ओवरीज इतने बड़े डेवलप नहीं होते हैं, तो उनके ओवरीज में दे डू नॉट हैव अ क्लासिकल necklace like pattern. They will not have, but they will have features of hyperandrogenism and their menses will be irregular. So उनके clinically उनके तो features will be like PCOS, but ultrasound में पता नहीं चलता है. So this is called type B PCOS. Type C PCOS are the patients who have regular menses. Their menses are regular. Okay. This means what happens, they will have features of hyperandrogenism. उनके पास hirsutism होगा, acne होगा, plus when you do ultrasound they will have PCOM, morphology भी present होगा, but their menses will be regular, they will not have irregular menses. And type D PCOS will be called beautiful PCOS. They are beautiful PCOS. They will not have hyperandrogenism. उनके hyperandrogenism नहीं है, तो they will not have acne, they will not have hirsutism. उनके दाढ़ी मूंछ नहीं होंगे. They will be beautiful females, but they will have menstrual irregularity and they will have PCOM in ultrasound. So these are the 4 phenotypes of PCOS which is found. Now since we have known all these things, let us know what are the differential diagnosis of PCOS. The most common differential diagnosis of PCOS is congenital adrenal hyperplasia. In congenital adrenal hyperplasia, there was 46xx. We have discussed in previous class, so you can kindly go back to my previous videos and see what is congenital adrenal hyperplasia. There is complete and incomplete type of congenital adrenal hyperplasia. They are females, and it is the most common cause of female pseudohermaphroditism. Pseudohermaphroditism. Okay, so 46xx. But what happens there, from the adrenal glands there is androgen production, DHEA is increased, and this DHEA gets converted to testosterone and dihydrotestosterone, and there will be male external genitalia. External genitalia will be like males, otherwise she will be female internally. So congenital adrenal hyperplasia. What is the treatment that we have discussed in neonatal life? Start dexamethasone to the patient. Dexamethasone is started, steroids are started, and steroids will help in prevention of the increase in body's androgen production. Okay, now this is the differential diagnosis. So how do we treat PCOS? Coming to management. Whenever in exam, always remember, whenever in exam somebody asks you what is the management, never jump to treatment only. Management को divide करना है आपको कि what is the diagnosis, how will you make the diagnosis, next how will you treat the patient, and then how will you go for follow up and prognosis of the patient. ये 3 parts में लिखना पड़ेगा. आप लोग क्या करते हो, सिर्फ ट्रीटमेंट लिख के बैठ जाते हो. यू हैव टू ऑल्सो राइट द डायग्नोसिस एंड फॉलो अप एंड प्रोग्नोसिस. फॉर डायग्नोसिस यू हैव टू राइट व्हाट आर द साइंस एंड सिम्टम्स एंड इन्वेस्टिगेशंस. साइन सिम्टम्स पता चलेगा एंड इन्वेस्टिगेशंस पता चलेगा, तभी तो डायग्नोसिस करोगे. And then comes the treatment and the follow-up and prognosis. So if somebody asks you what is the management of PCOS, start from signs and symptoms. That patient will have hirsutism, acne, all the hyperandrogenism features, then menstrual irregularities and everything. You have to start from there. In investigations, you will tell what are the blood investigations and ultrasound investigations. In ultrasound, the PCOM, that is morphology of the ovaries, you will tell. In blood investigations, you will get the hormonal levels done, that is serum free testosterone level will be done. Then DHEA level you can get it done. Other than that, you can go for LH and FSH ratio. You can test for prolactin to see why there is menstrual irregularity. Then you can also prolactin ho gaya. Then you can get done other markers also, like your CBC and RFT, and then go for glucose tolerance test, OGTT, to look for your metabolic syndrome. HbA1c can be done. These all things will be investigation. Coming to treatment. Treatment will be based on what symptom the patient is coming with, because we have 4 different types of phenotypes. Number 1, there can be hormonal agents which can be tried for irregular menses. Most of the patients will come with irregular menses. So what you do is, for regularization of the menses, you have to start oral contraceptive pills to the patients. Oral contraceptive pills are a very good type of management and treatment which can be given, because they not only decrease the menstrual irregularity, but they have non-contraceptive benefits also. In the long term, they help in reducing endometrial cancer, they help in reducing ovarian cancer. So they are very beneficial, and they are also useful for benign breast disease, benign endometrial disease. So all these things are reduced. So for menstrual irregularity, start theoretically oral contraceptive pills. Or at the same time, what you can do is, in the second half of the cycle, that is from day 15 to day 25, for the last 10 days, you can add medroxyprogesterone acetate. It is a form of progesterone. You can give 10 milligram OD or BD can be given, and then so there will be increase in progesterone, and after that you can withdraw it and there will be menses. Number 2, the second problem which patients will come with is your hyperandrogenism. So for hyperandrogenism also, the OC pills are the first line of management which are done. Apart from OC pills, if patient's hirsutism is very much more and it is not decreasing, this of course is the drug of choice. The second line drugs will be your, first of all, there can be an androgen receptor blockers. ओके, एंड्रोजन रिसेप्टर ब्लॉकर्स, एंड्रोजन रिसेप्टर ब्लॉकर्स का मोस्ट कॉमन एग्जाम्पल एंड मोस्टली यूज्ड इज स्पाइरोनोलैक्टोन. स्पाइरोनोलैक्टोन drug can be used. It is used in a dose of 50 to 100 milligram OD can be used. Apart from that, you have cyproterone acetate, cyproterone acetate, or you can also have flutamide. These are the drugs which are androgen receptor blockers. Apart from that, other type of drugs which can be used is, you have your 5-alpha reductase inhibitors. 5-alpha reductase inhibitors can be used. The classic example is finasteride, dutasteride. These are dutasteride. These are 5-alpha reductase inhibitors, and they are given in a dose of 5 milligram OD once daily. So these are some of the treatment which can be done. Apart from that, you can also use the laser epilation or removal of the hair from the face or skin. It can be done. For hirsutism, always remember, you have modified Ferryman-Galway score. Modified Ferryman-Galway scoring. Okay, so every time you are asked about the scoring system, this is very important. Ferryman-Galway scoring comes in your MCQ. So in Ferryman-Galway scoring, if you consider this as the individual, then we will count which part of the body has dense terminal hair. Okay, so starting from upper lip, lower lip. So initially there were 11 areas. Now we have 9 areas where we will look for hair growth. Number 1 is upper lip, number 2 is lower lip. Okay, means the lower part of the lip. Then third will be your chin. Okay, upper lip, lower lip and chin हो गया. उसके बाद your chest is number 4. Number 5 is abdomen में hair growth है कि नहीं. Okay, then comes your thighs. Okay, thighs is number 6. Then coming to the back. Okay, upper back and lower back will be 7 and 8. Upper back and lower back is 7 and 8. And ninth part will be your upper arms. Okay, arms के ऊपर अगर if there is hair. So these 9 areas are being seen in modified Ferryman-Galway score. अदरवाइज देर वे 2 more areas जो Ferryman-Galway स्कोर में लेते थे लेकिन मॉडिफाइड वाले में नहीं लेते. वो 2 areas है, अगर एग्जाम में कभी पूछे तो लोअर पार्ट ऑफ द लेग एंड लोअर पार्ट ऑफ द आर्म्स, दैट इज 4 आर्म्स. ये दोनों एरियाज पहले लिया जाता था, अब ये नहीं लिया जाता है. सो दीज 9 एरियाज में यू लुक फॉर द हेयर. इफ हेयर इज एब्सेंट देन यू विल स्कोर इट एज 0. इफ द हेयर इज प्रेजेंट एंड very much depending upon kitna present hai, density of the hair, if it is very dense you score it 4. So the highest marks will be 9 into 4, 36 is the highest score, and lowest score will be 0. If the score is more than 9 or above, so in the modified Ferryman-Galway score, if the score is more than 9 or above, then you say patient is having hyperandrogenism and the terminal hairs are increased. So this is how we grade it and we treat hyperandrogenism. The next problem which we all face is the insulin resistance. Such patients are very fat and they will have insulin resistance and metabolic syndrome. So for that the treatment of choice is lifestyle modification. So patients have to exercise a lot, they have to reduce weight. Reducing weight by 5 kg, if somebody reduces weight by 5 kg only, then around 70 to 80% of the symptoms of the patient will relieve and patient will have good ovulation being started. So lifestyle modification, weight reduction, decreasing junk food, weight reduction, decreasing junk food intake, and decreasing carbohydrate, whereas increasing protein intake. These all things can be done to reduce insulin resistance. Apart from that, you can start tablet metformin. Metformin will help in increasing peripheral sensitivity of insulin. So 500 milligram once daily can be started, increases to twice daily or thrice daily can be given. It also increases the egg quality in patients of infertility. So the fourth important feature with which patients come to you is infertility. So whenever patient is infertile, the main cause of infertility in PCOS is your anovulation. ओके, सो ओवुलेशन हो ही नहीं रहा है, ओवम नहीं बन रहा है, तो कहाँ से फर्टिलिटी होगा? सो इट इज़ द एनोवुलेशन. सो व्हाट यू डू इज़ you generally give ovulation induction agents, OI agents, ovulation induction agents. So what are the two types of ovulation induction agents which you know of? One is clomiphene citrate. Clomiphene citrate is a drug which is used. Clomiphene citrate, the lowest dose is 50 milligram once daily. It can be increased to 150 milligram once daily for 5 days in the cycle. Similarly, you have letrozole. Letrozole is a form of aromatase inhibitor. Aromatase inhibitor. It can be given in a dose of 2.5 milligram and can be increased to 7.5 milligram once daily for 5 days. So basically these 5 days cannot be given in any time. First day of the cycle is called day 1 when the menses start. So you generally give ovulation induction agents, that is clomiphene or letrozole, starting from day 2. Day 2 से हम start करते हैं once daily. So day 2, day 3, day 4, day 5, day 6. Till day 6 we give this 5 days of the cycle we generally give. And after day 6, from day 9 onwards, 9th day onwards, we keep on doing ultrasound and monitor the follicle growth. Follicle growth पता करते हैं. तो follicle growth means basically we are trying to look for ओवुलेशन इंडक्शन एजेंट देने के बाद हमारा फॉलिकल सही से ग्रो कर रहा है कि नहीं, डोमिनेंट फॉलिकल बन रहा है कि नहीं. डोमिनेंट फॉलिकल इज देयर व्हेन द डायमीटर ऑफ द फॉलिकल इंक्रीजेस टू 18 to 20 millimeters, दैट इज 1.8 to 2 सेंटीमीटर्स. जब इस लेवल पे चला जाता है देन वी गिव इंजेक्शन HCG and we hatch the follicle, and after 36 hours there is ovulation. So it is very interesting to know about the physiology, because how we generally monitor the cycles in patients of when they are undergoing IVF. So these are the basically the treatments which are generally given in PCOS. So PCOS में there can be the long term complications which can occur will be, long term complications will be, number 1, as I have already told, patients can develop metabolic syndrome and patient can develop type 2 diabetes. Diabetes mellitus type 2 can develop in long term. Number 2, there can be endometrial cancer because there is endometrial hyperplasia all the time. Number 3, patients can have heart disease because there is deranged lipid profile and there can be heart attacks and all these things in the long term. And number 4, of course, is metabolic syndrome. Metabolic syndrome has its own side effects because patients will have morbidity later on in life. So the question that sometimes is asked, can thin people have PCOS and insulin resistance? Yes, thin people can also have insulin resistance, but of course obese people will have more of insulin resistance than this thing. Can ovaries be normal? Yes, ovaries can also be normal, because in adolescent PCOS ovaries are normal, that is type B phenotype, but there is hyperandrogenism and there is your menstrual irregularity. So these all things have to be known, and insulin being high and insulin resistance is one of the important factor for metabolic X syndrome. So this is all about this chapter PCOS. I hope you all have enjoyed the PCOS. Try to read it properly, do your MCQs today itself, and then master the subject. Thank you so much.